Sachin, start.
Yes. Good evening, everyone. I am Dr. Sachin Patil, MAHAIP Executive Board Member 2025 from Yavatmal, and it's my pleasure to welcome you all on the second episode of Friday Ka Panch MAHAIP Ke Sang, along with my colleague Dr. Nikhil Patak. He is a Executive Board Member Central IIP 2025. Tonight, we have assembled an exceptional panel featuring 5 distinguished speakers, each representing one of Maharashtra's 5 regions, and 2 eminent experts in the field. Our focus for today's evening is pediatric emergency in office practice, a topic of paramount importance in our day-to-day practice. We are thrilled to share the knowledge, insights, and experience with you. Your participation and engagements are invaluable. Let's make this session more informative, interactive, and memorable one. So thank you for being the part of MAHAIP Friday Punch. Most important thing is we can earn a 1 credit hour for this. So please enter your name, mobile number, a central IP number, and MMC number in the chat box. Now I request our respected Maharashtra IP President Dr. Sanjay Pakmode sir to give a welcome address. Over to you, Pakmode sir.
Namaskar. Good evening. Happy Dhuli Vandan. Yesterday we have done the Holika Dahan and today we have celebrated the Dhuli Vandan. This Dhuli Vandan is in the Vidarbha is very much celebrated. All clinics are also closed now. Every shop is closed. Everything is closed. So once again, I welcome you all on this beautiful program of Friday Panch MAHAIP Ke Sang, a beautiful concept which is inclusive of all the members from all presenters from all the regions of Maharashtra. So the real MAHAIP program, I can say it, where we get a representation from the every region of the Maharashtra and with the 2 experts. And we know this pediatric emergency is a very important thing. Now, this pediatric emergency, it may involve a trauma or illness which requires immediate attention so that it could not cause any harm or disability or any permanent thing in the life or even the threaten to the means life-threatening thing. So which requires immediate attention. How it differs from the adult medicine, because the pediatric body is not a miniature of the adult. It totally differs from the adult. So because being small in size, smaller anatomy and everything, so here we require experts who are well versed and well trained in that particular field, as well as the supportive staff which is also well trained, and also the equipments. So all these things we are needed so that we can do the justice with the child and his family. Now this again, it differs from the adult medicine. That is, it is not restricted to the child only. It extends beyond that child because it involves the child's parents, child's family, and even the community. So this is the beauty of pediatric emergency. The one who are experts in this particular field are really an asset to the pediatricians or our pediatric population or even for the community. So here today we are discussing the 5 different topics of pediatric emergency, and 5 presenters will present the 5 different cases right from the preparedness in the emergency department with the experts like Mahesh Mohite sir. So I welcome you all, and I welcome all the office bearers of MAHAIP, our secretary, Dr. Dynamic Secretary, Dr. Amol, the scientific chairperson, Dr. Minhas sir, and CIPB, Dr. Nikhil Patak, and Sanjay Deshmukh as a convener, MAHAIP, Dr. Sachin Patil as the executive board members, and all other office bearers of MAHAIP, CIP who have joined for the today's program. And once again, welcoming respected Dr. Mahesh Mohite sir for this particular program. I hand over the mic to Sachin.
Thank you, Pakmode sir. Your words are always inspiring us for further IIP programs. Now I request our respected HSC Dr. Amol Pawar sir for welcome address. Over to you, Amol sir.
Yes, thank you, Sachin. First of all, I welcome respected past chairperson of pediatric intensive chapter of IIP and today's expert, Dr. Mahesh Mohite sir, then our president, Dr. Sanjay sir, Minas sir, Sanjay Deshmukh sir, all the five speakers, moderators, Dr. Nikhil, Dr. Sachin, and also not to forget our MMC observer, Dr. Rajendra Kulkarni sir, who is also senior pediatrician from Nasik, well-known personality in IAP as well as state IMA, and also he was past executive board member of Central IAP. So this is very well chosen topics by Dr. Minas sir and all the young speakers from all parts of Maharashtra. Already Sachin has told the theme of this program. So all the topics right from emergency preparedness, then another one catchy topic that is BRUE, that is brief resolved unexplained event, which will be dealt by Dr. Rohan Bobde. Then Dr. Jitendra Talekar sir is there from Solapur, and all the speakers are from various parts of Maharashtra. Almost 220 people have joined for this very interesting program. Many of us are general practitioners, and uh, there are very few people who are now dealing with the PISU because of lot of hard work involved in managing these pediatric intensive patients. Many of the general practitioners, they are uh, keeping themselves away from managing these patients. So whatever the knowledge we'll get, we'll try to put it into our practice. So I wish all the best to all the five speakers, and over to you, Sachin, for further proceeding.
Thank you, Amol sir. Now I request today's MMC observer, respected Dr. Rajendra Kulkarni sir. Dr. Rajendra sir, Kulkarni sir.
पेशंट बघत असतील पुढे जाऊ
बरं.
आपण.
Now I over to you, Nikhil, for further proceedings.
So moving further, let us get some few words from Dr. Sanjay Deshmukh, who is the convener for MAHAIP for today's program. Sanjay sir.
Good evening. Firstly, wishing you all the best wishes on the Festival of Colors. Happy Holi to all of MAHAIP members. And very happy on the Festival of Holi. I was confused. I told Sachin and Amol, is it possible to conduct this webinar? And now we can see more than 200 people are joining. So it's hats off to our scientific team, Dr. Minas sir, and our dynamic Dr. Amol, President Dr. Sanjay, our today's moderator, Dr. Nikhil Pathak and Dr. Sachin Patil. And the platform is for the young pediatricians who want to represent on the MAHAIP platform. And this is a great opportunity for them. And today we have the stalwarts, Mohite sir and Dr. Gupta sir from Delhi. I was fortunate to work with Dr. Mohite sir in 2017. Sir, welcome, sir. And we wish all the best to all the young faculties from Pan Maharashtra, because this is the platform MAHAIP want to give to them to represent the talent which is hidden in the Maharashtra. So best wishes and happy Holi again.
So moving further, today we have Dr. Mahesh Mohite, our expert, who is an past intensive care chapter chairperson, and I have seen him closely since I have seen him nearly 1.5 decades, where he has worked extensively in intensive care, understanding the intensive care to his basics. So if you give him a topic which is not done and which is very hard, he will be more interested to present it. He will himself like to research everything and present it. So we are fortunate enough to have his experience, his clinical acumen for us. And as we all know, he is attached to Sai Child Care Clinic, Panvel, and BJ Hospital, BJ Wadia Hospital. So welcome, sir. Mohite sir.
Yeah, I'm there.
Yes, sir.
I'm there.
Yes, sir.
Yeah,
Yes,
thank you very much. Yeah. So thank you, Nikhil. Just briefly, I think that the topic you have chosen is really very important, whether you like it or not. Every pediatrician must be able to deal with these emergencies. So, I mean, simple things. Some child is in the neighborhood is brought with some burns. You should know what to do in the primary emergency. Somebody is brought with some unknown bites. You must know what to do with that, because you can't just say that go to this hospital and go to that hospital. Child may be very sick enough, may not be reaching there. So at least the first aid you must know. Anaphylaxis is something a nightmare. I don't know how many of us have seen it on day-to-day basis or maybe in their lifetime. But whether you like it or not, you have to be prepared with those knowledge. And I'm sure those topics today are really very nicely selected. IIP Maharashtra has always been very innovative about the academics. Last almost 5, 6 years, I am seeing this on the regular basis. Some new, very interesting kind of programs are launched, which is attracting, I mean, majority of the pediatrician from Maharashtra. So thank you very much for inviting me to be a expert in this. And I'm sure all of us will learn a lot from this particular session. Thank you very much. Thank you, Nikhil.
Welcome, sir. Sachin, so
Yeah.
we can start further.
Thank you, sir. Now I will introduce all the speakers. The first speaker is Dr. Deepika Mashakar. She had done MD-DCS and fellowship in neonatology. She's a consultant pediatrician and intensivist at Bhosle Hospital, Latur, and she will be talking regarding the emergency preparedness in pediatric clinic. Then next speaker will be Dr. Rohan Bobde. He's from Amravati. He done MD Peds and FPCC, pediatric intensivist at Parijat Hospital, Amravati. Next speaker is Dr. Jitendra Talekar, sir. He's from Solapur IIP. He'll be talking regarding the anaphylaxis and its management. And after that, the next topic will be bee and wasp stings treatment and prevention. The speaker for that is Dr. Narjohan Mishram, sir. And the last topic, that is the Rabies post-exposure prophylaxis protocol. That will be delivered by Dr. Ujwala Sirsat, ma'am. She is from Ahilanagar IIP. Now she is a current secretary for the Ahilanagar IIP. Now I request Dr. Deepika, ma'am, to please start the session.
Okay, sir. Am I audible?
Yes.
Okay, I would like to share my screen. At the outset, I would like to thank MAHAIP for giving me the opportunity. Good evening, all the respected seniors. Today's talk for me is emergency preparedness in pediatric clinic. This topic particularly is meant for peripheral pediatricians who are practicing just general pediatrics. They are not more into the emergency pediatrics. Why to emphasize? This is the object. Let's see the objectives of today's talk. Why to emphasize the need for emergency preparedness in the pediatric clinic? Let us review the essential emergency equipments and medications required in the office settings, and let us understand the role of preparing entire team in the management of emergencies. And at the end, we'll just see how to recognize and treat some common pediatric emergencies. Coming to what is the need for emergency preparedness in a small clinical setup or any pediatric setup. Let us see the case. In a busy OPD day, a 9-month-old infant is brought with history of cough, cold and fever since last 3 days. The mother says that there is a breathing difficulty since morning. As there were more patients, the receptionist just completes the registration process and sends them in the waiting area. Few minutes later, the mother comes back to the desk and says that the baby has become blue and he has stopped breathing. The receptionist immediately informs this to the doctor. The doctor rushes out to the OPD and sees that the child has become dusky and had an apneic spell. The doctor immediately takes this child to ward and connects oxygen and asks for the ambu bag. But the receptionist doesn't know what is an ambu bag, and it was not being in use for last few months. She doesn't even find it. Then, even if she finds what size of mask or bag to get, does she know that? And who knows where it is kept? What happens in such scenarios? Let us see. Where do we fall short? The studies have shown that whenever a general pediatrician or a clinician in a small clinic or a small hospital setup where there is critical care is not appropriate, they generally wants to get rid of such patient. Why? Because studies, there are number of studies from US, UK, and various parts of country, even in India. These clinics, they lack the infrastructure, maybe due to the non-availability of adequate equipment or lack of trained staff. As we all know, we are many of us are still dependent on the non-medical staff for our help in the medical field. We don't have adequate number of trained nurses, and many of us are still lacking in confidence to manage such emergency cases, as we have already discussed. And there is a no proper developed protocol which is seen in these cases. Though they are there, there are some protocols, but people are not aware of these protocols. And ultimately, any pediatrician, they don't want the death to occur in their OPD or their clinic. Just nobody wants to face the medical legal implications. So what is the role of the pediatrician? But still these days, many of us, we face such cases like emergencies, may it be a life-threatening emergency or non-life-threatening emergency. We face these cases in our OPD almost once in a month or once in a week, depending on the number of patients you see. In such cases, what is the role of pediatrician who is at the first contact of the child? The pediatrician or the practitioner should recognize the sick child immediately, try to stabilize the child, and then only shift the patient to higher center. What this what this does is, we are sensing the child, we are finding the child in the golden period, and we are treating, so as the chances of survival are more. Coming to the essential emergency equipments which are required for every clinical setup, may it be small or may it be large clinical setup. These are the few instruments which are must for every clinical setup. These are oxygen source, oxygen tubings, nebulizer, suction apparatus, suction catheters of various sizes, suction and different ambu bag like pediatric bag, smaller for preterms and term neonatal ambu bags and adult bags, and different sizes of mask. Because pediatrics, as we know, the population varies in size according to the age. We have to keep all these equipments ready and are organized. Then oral airways, non-rebreathing mask. Non-rebreathing mask is must to have in each and every pediatric clinic, because it is the only emergency way to give 100% oxygen in an emergency. And then laryngoscope with different sizes of blade, like straight blade and curved blade in different sizes. Endotracheal tubes, cuffed, uncuffed. Intraosseous needles, different sizes of cannulas, IV tubing, syringes, BP cuffs, and pulse oximeter. This is all about the essential equipments. Desirable equipments which should be there in the clinic are glucometer, nasogastric tubes, Foley's catheter, and pediatric length-based tapes. Coming to pediatric length-based tapes, these are Brucello's tape, which are recommended by the Pediatric Advanced Life Support. These are very useful tapes for us, which gives us a gross idea of pediatric patient in an emergency. Because we give dosage according to the weight of the patient, we cannot weigh the patient in an emergency. So these tapes, we can keep it besides the patient. The rule is red to head. Red side of the tape is kept on the head side, and we just see the color code in which the patient falls. According to color code, that color code helps us to give adequate appropriate amount of dosage of medications for that child, and what equipment should be used for that particular child. These tapes are very useful for the paramedical staff as well, so that even in your absence, if they are properly trained, they can use these tapes and act accordingly. Coming to the essential medications which are required, most essential medication everybody should have in their OPD is epinephrine. Adrenaline 1:1000 what we get, and I recommend that adrenaline, everybody should make a ready solution of 1:10,000 adrenaline, mixing it normal saline every day, as it is needed. It is the must in any case of emergency or anaphylaxis. Anaphylaxis, though we are giving IM adrenaline 1:1000, but in case of CPR, we need 1:10,000 adrenaline, and which has to be made fresh every time. Then other drugs are like normal saline, salbutamol if you are facing a case of status asthmaticus, IV lorazepam or midazolam nasal spray if you are facing case of seizures or status epilepticus. Then steroids, dexamethasone, hydrocortisone, atropine, IV fluids dextrose 25%, dextrose 50%, certain antibiotics like injection ceftriaxone for treating the cases of severe sepsis, then IV paracetamol for high-grade fever. These are at least the minimum number of initial medicines which are required to be kept at our clinics. And all these medicines should be routinely checked by the staff for their expiry dates as well as availability. If the medicines are used up, they should be restocked every time. And all the instruments, whichever we are keeping in our OPD, like laryngoscope blades, then the number of the ambu bag, the number of ET tubes, everything should be repeatedly checked. It is recommended by AAP that it should be checked at every shift change, so that we should train our nurses so that they can give a proper handover for all these things. And staff training. Coming to staff training, AAP has got a policy statement made in 2007, which has been reaffirmed in 2011 and 18. It indicates that you should train all the staff in basic life support as well as advanced life support. And this helps to protocolize the resuscitation or any emergency situation to tackle, and everybody will be given pre-assigned roles for resuscitation. And this is a very important way to improve in emergencies. Training and team preparation. At least in our settings, we should train the staff to recognize, because children are very young and fragile and they are not able to tell their own symptoms. We should train our staff to recognize at least these following symptoms. These are labored breathing, cyanosis, stridor, audible wheeze, grunt, stupor or coma, seizures, vomiting after head injury, uncontrollable bleeding, poisoning. All these symptoms should be immediately attended. Role of mock course and protocols. Mock, mock emergency drills and team-based simulations are always helpful for ensuring the readiness of a clinic. In mock course, we have to simulate the situation of emergency, try to mimic it as an actual emergency. We have to involve everyone. May it be your mama, may it be your maushi, may it be the watchman, may it be the staff, paramedical staff and the doctors. Everybody should take part in this mock course, and these should be conducted on a periodic basis, maybe once in the 3 months or once in the 6 months, and make a protocol for documenting each and every event, and then debrief your strengths and weaknesses. We can learn from debriefing, we can learn from our mistakes, and it is always recommended to make a written office protocol for that particular clinic. You can display the flowcharts of the emergency protocols on the walls. And scavenger hunts. Scavenger hunts are important for checking the preparedness of the new office staff. What is scavenger hunt? Like if there is a new staff to your clinic, and you can tell them after a few months, like they go get the ambu bag, go get the laryngoscope, go get the laryngoscope number with the blade number 1 or 0. And we have to we can check by this way, we can check the staff whether he is knowing exactly what is laryngoscope or what is the ambu bag and where it is kept, whether it is working or everybody knows. These types of techniques we can use to improve our own OPD setups. And definitely regular check of the emergency equipment is needed. Once we stabilize the child primarily, we have to transport the child as soon as possible, and the transport should be at the nearest emergency referral center, because the least time you waste in transport, the more advantage will be towards the baby for the survival. So before transferring the baby, we have to have a proper communication with the referring center. This will help the baby. This will help the referring center to be prepared for receiving the baby, as well as there won't be any problem like shortage of bed or any other non-availability of ventilators, etc. And it is always recommended to send accompanying staff who is trained in medical resuscitation or advanced or basic life support care. And the last and most important thing is documentation. The referring pediatrician should record the dates and time of treatment, stabilization attempts and medications given with the dosage. For example, if a child is coming to you with status epilepticus and you have loaded him with maybe phenytoin or Gardinal, you have to mention how many loading doses you have given and what all events have occurred, and you have to mention the condition of the patient at the time of departure from your clinic. Looking at the common emergencies what we face during our clinic are most common emergencies we face are respiratory like croup, status asthmaticus, severe pneumonia, bronchiolitis, foreign body aspirations or choking. Next to that, circulatory emergencies like dehydration, shock, which are commonly seen, and febrile seizures, status epilepticus, are also commonly seen in our OPD. Not to forget anaphylaxis, polytrauma, burn, diabetic ketoacidosis, etc. What is the learning objective for the pediatrician who is coming across such cases? The most important thing is remember 3 R's, that is recognize, resuscitate, and refer. So, whenever you are seeing a patient, you should know what is the status of the patient. We all know there is a very beautiful protocol given by this pediatric advanced life support. Everybody should follow that. So whenever you are seeing a patient, you should see the pediatric assessment, PAT assessment triangle, seeing the appearance, breathing and color of the patient. We will know whether the patient is conscious, patient is having normal breathing or increased work of breathing, or the patient is having pale color which indicates shock. So after initial impression, if the patient is sick, non-responsive, you have to immediately act like if the patient, you have to check the pulse of the patient, start CPR. If the patient is moderately sick, you can go for the primary assessment. Primary assessment includes airway, breathing, circulation, disability and exposure. Coming to the airway, we have to see whether the airway is open, maintainable or non-maintainable. For example, if there is any airway obstruction, if you get a patient, infant with a choking or airway, some foreign body obstructed in his trachea, then what you have to do, you have to act immediately. You have to hold the baby on your lap, give some back slaps or chest thrust, or if there is an older child, you can use Heimlich maneuver as well. And then stabilize the baby. Look for the breathing and classify whether the baby is having respiratory distress or respiratory failure, depending on the situation of the patient. If the child is having respiratory distress, there are certain conditions which we commonly come across. Respiratory problems which we see are viral croup, foreign body aspiration, facial diphtheria, status asthmaticus, bronchiolitis, bacterial pneumonia, or any disorder control of breathing. In all these situations, first and foremost duty of a pediatrician is to stabilize the patient depending on the appearance, breathing and color of the patient, and then give humidified oxygen and do whatever is needed at the primary setup. Like if a patient of BRUE comes, you give nebulized epinephrine, give a single dose of intramuscular dexamethasone of 0.6 mg per kg and stabilize the patient, and with oxygen you can send the patient to higher center. Coming to circulation, we have to identify whether the child is in compensated shock or hypotensive shock, and depending on that we have to immediately intervene, like put an intraosseous needle and give a bolus and stabilize the child, start oxygen and then send to higher center. Similar things, we can see lots of cases of diarrhea and dehydration which are needing emergency intervention, so that the child should not go from the compensated shock to hypotensive shock. That's why we should always remember that we should address the circulatory problems and then send to the higher center. Coming to disability, disability gives us the gross idea about the mental status of the patient. If the patient is found unresponsive, you check for the pulse, and if there is no pulse, you start immediate CPR. And if the patient is having low GCS like stupor, then if the GCS of patient is less than 8, it is recommended to electively intubate the child before sending him to higher center. Similar thing applies to hypoglycemia. Always give a bolus of dextrose before sending the patient to higher center. Then coming to the exposure, before before sending the patient, we have to expose the patient and see for all over the body if there is any there are any chances of bruises or there are any active bleeding marks. In that case, you have to apply pressure bandage. And if at all there are some, in case of trauma, if at all there are some wounds, you have to surgically intervene, like suture the patient before sending to higher center. And once you stabilize with primary assessment, then you can go for secondary assessment if time permits. That gives sample history and a focused physical examination. Again, the cycle of evaluation, identify and intervene should be followed after each assessment. Coming to different emergencies like seizures, if we get in our OPD practice, what is the goal of therapy? It should be maintain ABC first, differentiate if the child is having cortical or brainstem dysfunction, see the GCS. Depending on that, you should remember, like if the GCS is low, you have to intubate the patient. Try to control the seizure. Don't let the patient land up in status epilepticus. Give primary anticonvulsants like midazolam or lorazepam. Stabilize the patient. Give a loading dose of anticonvulsant. See for respiratory status, hypertension and all. Treat that and then send the patient. As the anaphylaxis is being discussed later, I am just mentioning this in brief because many of us come across such situations in clinical practice. Anaphylaxis can happen anywhere to any drug, like a vaccine or a normal common drug, antibiotics, which we are regularly giving in the clinics. Every person should know how to tackle anaphylaxis. If you are seeing a patient with rash, oral facial swelling, sudden development of respiratory distress after some ingestion of food or medications, or there is vascular collapse, the child should immediately be attended. Give secure airway breathing circulation and then give adrenaline IM dose 0.01 milligram per kg, which should be repeated every 15 minutes. Treat the bronchospasm with giving salbutamol nebulization, and endotracheal intubation is needed if at all there is impending respiratory failure. Discussing trauma in brief. If there is a case of trauma, anticipate airway obstruction, expose the child and stabilize the cervix fully to see for any bleeding marks, stabilize the cervical spine, open and maintain the airway by jaw thrust, not to damage the cervical spine. And if there are signs of shock or consider shock may happen, so start IV fluids. To conclude, being prepared for emergencies in pediatric primary care settings is very critical for ensuring the positive patient outcomes, and maintaining well-trained staff, essential equipments, and following ALS and BLS protocols, we can provide timely and life-saving care in emergency situations. Thank you.
Thank you, Deepika ma'am. Over to you, Dr. Mohite sir, for your expert comment.
Yeah, I think Dr. Deepika has extensively covered the topic, almost every aspect of it, maybe slightly more than what we expected from this particular talk. I think preparedness is all about, as I told you, this is something which will come in any emergency, whether it is IPD, OPD, ICU, emergency room, or even at your home, frankly. So you should be prepared with at least the basic equipments of airway breathing, circulation, and disability stabilization. I mean, I'll give you a simple example. If you are traveling on the road and you meet with like some road accident has happened, as a doctor, I think it's a good idea to have your emergency kit even in your car. At least something to take care of airway breathing circulation. If that can be done there, your clinic. In fact, in our smart clinic module, this particular section was discussed very detailed, and what all things go like. We have those equipment, but how often we check them whether they're working daily or not. So what is important is to maintain a checklist of the equipment and services in general, and checklist for at least common emergencies that you deal with. So your oxygen cylinder is there, but whether it is full or not. Your adrenaline is there, whether it is within expiry or not. Your ambu bag, laryngoscope, are they working or not? So I think Dr. Deepak has already mentioned that every duty, the functioning of each of those equipment has to be checked wherever you're working. I think that was a very good extensive coverage of the particular topic of preparedness. Preparedness, perhaps we didn't expect the management aspect of it, of every individual, which we'll be discussing subsequent part. But preparedness is all about how you are ready to accept any emergency at any situation, whether you're in the OPD, IPD, ER, or something. And I think that part you have covered very well. Thank you very much.
Thank you, Mohite sir. Your inputs are always useful for us for our day-to-day practice. Now, the next speaker is Dr. Rohan Bobde. He will be talking regarding the brief resolve unexplained event, that is BRUE. Rohan, please start.
Yeah, thank you everyone, and happy Holi to you. After this extensive talk, I'll be just having a short talk on brief resolved unexplained event. So Yeah, we all have idea what this is. It's an apparent life-threatening event. So in 2016, AAP suggested that a life-threatening is not a proper term for such events. So they removed it and then they changed it to BRUE, that is brief, resolved, unexplained events. So the name itself is a definition. So we can see that the event is a brief, uh, usually ALT or brief resolved unexplained events are occurring in infants less than 1 year. So these events are really very brief, lasting for less than 1 minute, usually just 20 to 30 seconds also. These are resolved events. So within a minute, the child comes back to baseline, and within a minute, you can see that child was completely all right. But the events are so scary for caregiver and relatives that it causes panic, and the parents usually come to a pediatrician or a clinician in a panic state. So these are unexplained events. There is no any identified medical condition for such events, and these events are usually occurs with change in color. That is, the infant can be uh, present with cyanosis or pallor. There will be change in breathing. That is, there could be apneic episodes. There could be distress lasting for a few seconds, few minutes. A change in tone. The child can be hypotonic or hypertonic, and change in responsiveness. There will be sudden irritability, sudden shrill cry, or um, no response from the child at all for few seconds. So um, this these episodes can be very scary, even for a pediatrician. If something like this happens in front of us, so even we will get scared. It will be very scary for a parent of an infant to see their child having such events. So, mind you, though these are they resolve back to baseline very quickly, there can be some underlying pathological reasons that can cause such events. So for that, we need to know what risk factors are there. So if there are repeated episodes of such brief resolved unexplained events, the child was less than 32 weeks, there is prematurity or low birth weight. The child is less than 2 months. There is history of recent illness, mainly lower respiratory infections like bronchiolitis or high grade fever, or there is feeding issues. So if such risk factors are there, we need to go in slightly. You have to investigate a little further and go in detail. Otherwise, if such risk factors are not there, the low risk children are usually safe. So what is not a brief resolved unexplained event? So yes, SIDS or near miss SIDS or aborted crib death, these are all older terms, and these are not included in BRUE, as these are resolved events. So um, reflux after feeding, severe infections, birth defects that involve face, throat, and neck, birth defects of heart or lung, allergic reactions, brain, nerve, or muscle disorder, child abuse, and certain uncommon genetic disorders. They can have such events. They can present with such events, and they will have multiple. They can present with many such events in very short time. So we will not classify them in uh, BRU. So as the name suggests, the pathophysiology is unexplained. So there is no explainable pathophysiology for this. But studies are going to uh, correlate if there is anything going on with laryngospasms, GER, abnormalities in swallowing mechanisms, or autonomic dysfunctions. But at present, there is no identifiable pathophysiology. Now, as we have to rule out all the serious conditions, we have to go through a thorough history. In such cases, the general history requires the location where the child was at the time of such event. Was he at home? Was he at play school? Was he with a stranger? Was he with the parents? Was he awake? Was he asleep? What was the position of the child? Was he in prone position? How was the activity of the child? We also need a thorough description of the event. Was the child quiet or active? Was he responsive or unresponsive? How was the breathing pattern before and after this event? Was there choking or gagging? Was the child limp, rigid, seizing, or alarmed, or anxious? How was the color of the child? How much duration this episode lasted? Was the event terminated abruptly or gradually? Was any intervention required? Was the termination happened when the parent picked up the child? Was this event terminated with that? Or even if CPR was required to terminate such event? So also, the history of past illnesses, like was there any recent illness, or what was the antenatal history of that child? What is the parental history of that child? Were there similar episodes in past? Uh, is there developmental delay, family history of sudden deaths and arrhythmias? All these are essential to rule out any high risk and any underlying medical conditions. So, in low risk cases, just clinical examination for few hours, 4 to 6 hours of observation is sufficient. We need not do any more tests or any more investigation in such cases. But if there is a high risk case, hospitalization with 12 lead ECG and vitals monitoring is essential. So, and as we find out, and as we find out there can be underlying medical conditions. So investigations according to that will be essential. So there is no treatment required for a low risk case of BRUE. Only close follow-up is essential, and training for CPR. The child having an episode of BRUE can have a repeated episode, so the parent needs to know how to handle that episode and if the child is not recovering, and how to give a CPR also. So for differentials, we need to know that such thing can also occur in respiratory infections like pertussis or bronchiolitis. Sepsis and meningitis can also present the same way. GERs can also present the same way. Seizures can also be underlying cause. Infant botulism, prolonged QT syndrome, metabolic disorders, and child abuse has to be kept in mind always. Thank you.
Thank you, Rohan. Now, Dr. Mahesh sir, your expert comment, please.
Yeah, I think Rohan again has done a wonderful job here, covering almost everything. Just some few basic concepts. This is a new terminology given for the old problem. BRUE is not a diagnosis in itself. It's just kind of a small subset of patients where we could not allocate the exact cause to that sudden severe incidence. Now, this is given predominantly in the children less than 1 year, infantile age group, not for the bigger children. And whenever you have a definite history suggestive of some underlying pathology, say underlying respiratory infection followed by some apnea or something like that, or child already had some cardiac event and then subsequently comes up with a sudden stoppage, or on clinical examination you can allocate that particular event to some clinical pathology, then that is not BRUE. BRUE is something where you could not get a definitive diagnosis, but otherwise child is physically absolutely normal. And this is that child who is to be labeled as BRUE and perhaps requires to be observed in subsequent event. Now, still this particular terminology and this thing is evolving. There are multiple literatures are available, but this is small subset which is potentially dangerous, but not to be aggressively evaluated at this point of time. So I repeat again, there is no definitive indicative clinical history or there is no definitive clinical abnormal pathology which can be clinically detected, then that is to be labeled as BRUE, especially in the children less than 1 year. Olden days, we had those SIDS and all those things, near miss SIDS and all those things which were again enigma to us. Classical scenario is breath holding spasm. That also can be taken as BRUE because parents don't, they give their own version of the pathology and sometimes don't know whether it is seizure, whether it is kind of a breath holding spasm or something else. And that can be labeled perhaps under this broad terminology of BRUE and can be observed subsequently. One, when you're in doubt, these kind of patients, they have a possibility of again crash next time. So two, three things, if you're seriously kind of contemplating a serious underlying pathology, then parents can be trained to do a bag and mask at home. Quite often, these extreme preterm babies, when we discharge them, we do train the parents for a bag and mask at home. So this kind of pathology also, you can train the parents to do at least primary resuscitation at home, so that a particular pathology, particular kind of a event can be avoided. Secondly, if you feel it's not really very critical or you have any doubts of seizure or something, then in the present era, everybody is carrying a smartphone. You can tell the parent to record next event. So one person looking after the child, other parent can even record the event. And that the visual impression of of a parent and visual impression of a doctor makes a huge difference. By just observing a particular event on a video camera, kind of a video, you can definitely give a much better input than just empirically treating this child. That's my input about it. Something more than I think Rohan has done a good job overall in presenting this particular scenario. Thank you.
Thank you, sir, for your insights for the topics. Now, next topic is anaphylaxis and its management. Over to you, Dr. Jitendra Talekar, sir, from Solapur, IP. Jitendra, sir.
Yes, sir. Hello, everybody. Can I audible?
Yes, sir.
Yes.
Yes, sir.
Yes.
And PPT
Okay,
is
happy
also
Holi.
visible.
First of all, today's my topic of discussion is anaphylaxis and its management.
Just click on the screen, sir. It will go like for the next screen. And click next. Yes.
Okay. We will go through this topic under the following headings. That is definition, epidemiology, what is the pathophysiology, what are the clinical presentation, how will you diagnose acute and long-term management, recent advances in the management of anaphylaxis, and what are the prevention strategies. Okay. Now, what is the definition of the anaphylaxis? Anaphylaxis is basically the acute rapid onset, occurs within the minutes to several hours, potential to cause the death. It is a life-threatening condition, and it may be the IgE mediated or the non-IgE mediated systemic hypersensitivity reactions. Now, in epidemiology, the incidence of this anaphylaxis is 2.1 per 1,000 per person, and majority of the new cases is diagnosed in the children under the age of the 4. And common trigger factors for this anaphylaxis in pediatric population is the food allergen, followed by the insect stings, followed by the medication. Now, what is the pathophysiology? So this is basically the IgA mediated response with release of the mediators and followed by the systemic effects. So whenever there is an exposure to an allergen, there is a cross-linking of these IgE antibodies to the mast cells and the basophils, and that triggers their activation with the release of the mediators of the inflammation. That may be the histamines, leukotrienes, prostaglandins, and that causes the systemic effects. So this pathogenesis may be the immunologic, that is IgE mediator, some other non-IgE immunologic this mechanism, and last is direct activation of these mast cells. So these are some trigger factors in the immunologic IgE mediated response, that is food, insect stings, medications, and some other substances like latex. In the non-IgE mediated, there is a complement cascade activation, coagulation pathway activation, and the direct mast cell activation. That is physical factors like the heat, cold, sudden exposure to heat, cold, and it also the exercise or some medications like the opioids. Now there is activation of the mast cells and basophils with the release of the histamine, tryptase, carboxypeptidase, prostaglandins, and leukotrienes. Now, these are the manifestations. There is systemic hypersensitivity reaction. So that occurs many systems involved in this anaphylaxis. The cutaneous manifestations may be itching, flushing, urticaria, angioedema. Respiratory system involves the cough, dyspnea, hoarseness of the voice, stridor, and wheeze. GI symptoms, persistent vomiting, abdominal pain, and diarrhea. Cardiovascular systems leads to dizziness, hypotension, shock, angina, and arrhythmias. And the central nervous system may be the this is headache and dizziness. Now, already we have seen this clinical manifestation. Most important cutaneous manifestation, sudden onset of the urticaria, angioedema, stridor, wheezing, bronchospasm. These are already we have seen in the last slide. Now, these are some signs which are difficult to interpret with the anaphylaxis. In general, there is non-specific behavioral changes, which are the persistent crying, flushing, or irritability. In skin and mucous membrane, there may be flushing. That flushing may occur sometimes with the high-grade fever or some crying episodes. I mean, the respiratory symptoms, there may be the hoarseness or dysphonia. That may be because of the excessive crying spell, or in the drooling or increased secretions in the which is common in infants, and that mimics the signs of the anaphylaxis. In GI symptoms, again, the regurgitations, loose stools, that may be the or colic abdominal pain in the infants. Cardiovascular system, that is hypotension, especially when the systolic blood pressure in a child of 1 month to 1 year, that is less than 70 millimeters of the mercury, but the appropriate blood pressure cup size, and 1 year to 10 years, less than 70 plus 2 into age. Okay. Now, which are the common triggers? It is food, especially the eggs, meat, peanuts, milk, soy, and fish. Some food additives, that is colorant, insect stings of yellow jackets, wasps, bees, some medications of beta-lactams, antibiotics, penicillin, ibuprofen, some biologic agents, natural rubber latex, and vaccines. So these are the IgE-mediated triggering factors. Now, these are some common trigger factors, but these are the non-IgE mediated. But maybe with exposure to the some physical factors like the exercise-induced anaphylaxis, sudden exposure to the cold, heat, or ultraviolet radiations, complement activation, sometimes some drugs like aspirin, NSAID, opiates, and some contrast materials which are used in the radiology, and some IV immunoglobulins. These are the trigger factors, but activate with the non-IgE mechanisms. Now, whom to suspect they will have the anaphylaxis? So those having the family history of atopy, eczema, asthma, allergic rhinitis, systemic mastocytosis, and the children with the beta-adrenergic blockers or the ACE inhibitors. Now, how will you diagnose? So main thing with diagnosis of this anaphylaxis is mostly on the clinical criteria rather than the some investigations, diagnostic tools like increased tryptase levels, because these are not specific, because it will because it rates after 1 to 2 hours after exposure to allergens. So diagnosis is mainly on the clinical criteria. So it is highly likely when one of the following of three criteria is fulfilled. So first is acute onset involvement of the skin, mucus, or both, and one of the following, that is respiratory compromise symptoms of the respiratory systems, and reduced blood pressure or associated organ dysfunction. Next, two or more of the following, with involvement of the skin, mucosal tissue, respiratory compromise, reduced blood pressure, and persistent GI symptoms. And third criteria is the reduced blood pressure after exposure to the known allergens. So this is the clinical criteria on which basis we will diagnose anaphylactic reaction. So this I already we have seen. So lab diagnosis is non-specific. Plasma tryptase level that may be elevated for a few hours after exposure, and that is not raised in some anaphylaxis occur because of the food allergens. Now, another entity we have to know here is the biphasic anaphylaxis. So here is the recurrence of the symptoms, especially resolution of the initial symptoms after the exposure to the specific allergen, and that occurs within the 4 to 6 hours after the resolution of the first symptoms, and that more common with the drug or venom-induced anaphylaxis rather than the food-induced. And that is 11 to 15% of the pediatric patients experiences this biphasic anaphylaxis. Now, these are the red flags in the anaphylaxis. So those having the history of the previous anaphylactic reaction, having history of asthma, hypotension during this episode of this anaphylactic reaction, having stridor, requires the fluid boluses. That means there is a shock or hypotension is there and requires more than one epinephrine injections. So these patients have, these are the red flags of the anaphylaxis. Now, how will you manage these anaphylactic reactions? So this is the immediate management. So first line and cornerstone of the management of the anaphylaxis, again, the epinephrine, and epinephrines. Already we have learned from the first speaker of that first line management is with the epinephrine, and that is intramuscular epinephrine, 0.01 ml per kg, but dilution here is 1 in 1000 dilution. And maximum we give 0.3 milligram in the children and 0.5 milligram in the adults. So dose is given lateral aspect of the thigh. Repeat 15 after 15 to 20 minutes if the symptom persists or the recur. So this is the first line management. Then again our ABC, that is airway, breathing, and the circulation. Position is also here important. Supine position with the elevated legs if there is hypotension, or the sideway if there is a patient having the distress or the vomiting on the side-on position. Sometimes we will require the oxygen with 10 to 15 liters per minute if the patient experiences hypoxemia and respiratory distress with the non-breathing mask. Now, if the anaphylaxis reaction, sometimes children experience this very severe reactions with the shock, then we have to give the this epinephrine with the by IV route. Then our dose is the 0.1 ml per kg, but the dilution here is the 1 in 10,000 dilution. And associated with, we have to give the volume expanders because child experiences the shock. So 20 ml bolus, 20 ml per kg of normal saline heavy bolus, followed by the 10 ml per kg per hour maintenance fluid. With this shock persists, then we shift over to the dopamine, that is 10 to 15 microgram per kg per minute. If there is a wheeze, then we go for the aminophylline and nebulization with the salbutamol. So we have already discussed in this, that is epinephrine. It is the most important. Dose is the 0.1 ml per kg of 1000 dilution. And if required IV, then it is with the 1 in 10,000 dilution, maximum 0.3 milligram for children, 0.5 milligram for adult. Repeat every 5 to 15 minutes. If no response, then IV and maximum dose, 0.3 and 0.5. Okay. So if the symptoms are mild, then we have to observe at least monitoring and observation at least 4 to 6 hours in well-equipped facility after these anaphylactic reactions. And extended observation required those patients who require the more than one epinephrine injection, having the hypotension, shock, and associated underlying comorbidities. Okay. And the first line is the adrenaline. Then there are some adjuvant therapies for this anaphylaxis reaction. That is mechanism. So the adrenaline acts with the alpha and beta agonist action. So this decreases the vascular permeability, and by the decreases the laryngeal edema, then cardiac and inotropic and chronotropic effects, also having the bronchodilator effect with the alpha and beta agonist activity. Then H1 and H2 antihistaminics, especially the diphenhydramine 1 to 2 milligram per kg, intramuscular or IV, and that relieves the cutaneous manifestations like the itching and urticaria, but not relieve the life-threatening respiratory symptoms. Then beta 2 agonist, that is nebulization with the salbutamol. Then glucocorticoids or the corticosteroids. So here the role of the corticosteroids is not in the acute management, but especially in the biphasic anaphylactic reaction or in the prevention and the recurrence of this anaphylaxis reaction. Corticosteroids are the main role, but not in the acute episode. So we will give methylprednisolone 1 to 2 milligram per kg or hydrocortisone 5 to 10 milligram per kg every 6 hourly. Sometimes local infiltration of this adrenaline, that is point 0.1 to 0.5 ml. If anaphylaxis occurs because of this drug injection or sometimes these insect stings. So these are adjuvant therapies. First is antihistaminics, H1 and H2 antihistaminics, corticosteroids, methylprednisolone or hydrocortisone, bronchodilators with the nebulization with the bronchodilators. And last episode, when the epinephrine is not beneficial or it is a patient is not responding to the epinephrine, then we have to go for the glucagon, that is 20 to 30 milligram per kg intravenously slowly over 5 to 10 minutes, especially those patients who are on the beta blockers. Here we have to use the glucagon to tackle this anaphylactic reaction. Now, some recent advances in the management of this anaphylaxis. There's again the cornerstone of the treatment is the epinephrine, but now there are epinephrine auto injectors are available and which are prescribed to those patients with having the high risk of the anaphylaxis. Now, these are some long-term management and prevention strategies, especially the immunotherapy, that is the oral immunotherapy for the peanut, milk, or egg allergies. And they have a very good success. Biological therapy with the omalizumab, they have some severe food allergies, school and daycare pruning. And first and foremost thing, avoiding the avoidance of the allergen and education to the parents and as well as the daycare center. Now, there are some special considerations in this pediatric anaphylaxis, especially in the infants and the neonates. Rather than getting urticaria, angioedema, and stryger, sometimes the only lethargy, pallor, decreased activity. These are some features rather than these common symptoms of anaphylaxis we get, and we have to suspect these anaphylactic reactions. Also, in some higher age group, that is adolescent, they're having the risk-taking behaviors and non-adherence to the management of the plans that require the emphasis on the self-management and self-management skill and peer support. So the prevention strategies for this anaphylaxis is the early allergen introduction, then maternal diet and vitamin D supplementation. Thank you.
Thank you, Jitendra sir. Over to you, Dr. Mohite sir. Please.
Yeah, I think Dr. Jitendra has really covered anaphylaxis very nicely. Almost every aspect of that he has given. Just a few inputs on it. Anaphylaxis is the common thing, but something which is, he said, non-IgE mediated, which is also called as anaphylactoid reaction, which is practically the same as anaphylaxis, with even the management part remain the same. But here, in the pathological parts, you don't see the IgE mediated response. But that is as common or rather more common than anaphylaxis. Second thing I want to say, any nth dose can cause anaphylaxis. It's not essentially that a first dose of any triggering factor will cause it. It may be nth dose. Typically, we used to see this in penicillin prophylaxis, which used to be given in the past. Like a particular individual has taken maybe 10, 15 doses or maybe a few years of doses, and some dose subsequently may post this anaphylaxis. So, because first time he didn't have it, doesn't mean that he will never have the anaphylaxis to a particular drug. So, as a practitioner, we should be prepared for anaphylaxis in the clinic any day. We have been giving vaccines so often. Any of the vaccines can give rise to anaphylaxis, either directly because of vaccine or the adjuvants which are put into that. Third, it's really acute emergency. Many times goes unnoticed, but if you see the clinical aspect of it, is almost 90% time the presentation is skin rashes, urticaria itself, and the critical presentation, the respiratory, the cardiocirculatory, is about 50 to 60%. Practically, whatever cases I have seen, a rash has been always preceded the cardiocirculatory failure. So keep your staff kind of preempted, and your parents, the patient groups. If child develops any pruritus or any rash or something, please report me. It's not that he will crash and they will start treating. If you pick them up right at the beginning with the rationale, give a single dose of adrenaline, quite successfully you can avert it, can revert. We have experienced, I myself have experienced not less than about 8 or 10 cases of anaphylaxis in my practice. I'm sure all of you must have seen that. You can save each of them if you are well prepared. That goes with the first talk of preparedness as this thing. Rest, I think you have covered everything well, not to forget the medical legal aspect. Yeah, it is a medical legally reportable emergency. You have to report it to the authorities if any child gets anaphylaxis. I think rest everything Dr. Jetan has covered very well. Congratulations. You have done a really good job. Thank you.
Thank you, Mohite sir, for your inputs. Over to you, Nikhil.
So our next speaker is Dr. Narjohan Meshram from Mumbai, and a young intensivist from Mumbai telling us something new. So over to you, Narjohan. So can you just share your screen?
Yes, sir. I will share my screen. So, are you able to see it? Okay. Hello,
Yes, yes,
I'm
it is
audible.
yes, you are
Yeah.
audible as well as visible.
Okay, okay. So, good evening, everybody, and happy Holi to everyone. I would like to thank MAHAIAP and Office Bearer, my seniors and friend, to giving me this opportunity to present. So, today I will discuss regarding bee and wasp stings treatment and prevention. So, it is a very common scenario in OPD, whether the child and adolescent come with any kind of bites or sting, and suddenly we notice there is some kind of body reaction to it, and it may be like a worrisome to parents as well as doctor also, because they tend to have a severe reaction following stings. So in order, I would like to just differentiate the insect. Basically, they come under order and genus of Hymenoptera, and it contains bees, wasps, yellow jackets, hornets, and ants. So these are the common insects we found in our day-to-day practice. So the order Hymenoptera capable of causing allergic reaction to the child and adults. So, what could be the allergic reaction to these stings? So, basically, it is a local reaction. Most of the children, adolescent, or adult present with immediate reaction, or they may present with the delayed kind of reaction. It is a local reaction to sting on the skin. Whereas, second kind of patient present with systemic allergic reactions such as anaphylaxis, or they may present with cutaneous systemic reactions. And third is uncommon reaction. Sometimes they present with delayed kind of reaction, that is serum sickness or vasculitis of different kind of organs. So these are very uncommon, but they present certain period of days. So I would like to just differentiate what are these kind of insects are. The first is wing Hymenoptera. They have wings. So they come under the most common is Apidae family. We see in day-to-day practice, honeybees, they have hives and bumblebees. So these are common bees we found in our environment. Second is Vespidae family. They have yellow jackets, yellow hornets, white face hornets, and paper wasps. So how do you differentiate between these two families? So you can see that these honeybees and bumblebees are round and oval in shape and little bit fatty as compared to these are slender and long bees, where is also known as wasps. So according to means phenotypic differentiation, we can differentiate in between two. But sometimes it become very difficult to differentiate in between them. So here we will differentiate them according to kind of sting they do. So bees versus wasps, they look similar in their morphology, but bees are generally more docile, more silent as compared to the wasps. So wasps is very much like aggressive kind of. So barbed stinger of the bee remain in the victim's skin, whereas wasps may sting multiple times. So the suppose honeybee sting is there, so that honeybee will sting only for once, and they may get died after the sting. Whereas wasps sting multiple times, and they will be still alive. So while there are other categories, the wingless Hymenoptera. So certain period of their life cycle, they have wings. Later on, they shed off their wings. So it contains Formicidae family that contain ants, fire ants, then harvester ants, bulldog ants, and jabjunker ants. So these are different kind of ants we see in day-to-day practice. So Hymenoptera generally sting people in self-defense. They don't sting like that. And if we disturb their nest or hives, they will sting. And these stings are actually painful and itchy. And patient is aware, the grown-up child is aware that they got a sting, but they don't know the insect what is it. And for adults also, it's very difficult to differentiate which kind of insect is. So we can just postulate that this insect could be whatever the insect in our environment. If there is nearby hives or nest, then we can think that this insect could be cause that sting. So it is difficult to differentiate since the resultant lesions are very similar when they bite, when they sting. So sting apparatus lodged in skin. So basically in the dermis, in the skin only, epidermis only, not in the dermis, and that drifts away along with the venom sac. So venom sac will be into the skin, and that need to be removed immediately within a several seconds. If we don't remove it, then poison will just diffuse at the site of bite, and sometimes it may remain for minutes also, so we need to remove within seconds. If it hasn't been removed, then it can cause a foreign body reaction as well. So whereas ant bites cause multiple stings with their mandibles, and here the removal of insect is needed, whereas in sting apparatus removal of sting is needed. So you can remove with credit card, hand, or any kind of forceps like that, so as soon as you find it. So what kind of reaction it could cause? So basically, first is most common reactions are local reactions. So it confines to tissue and it is contagious with the sting bite. Suppose here is the sting, and these all other contagious reaction because of sting venom. So these are mild and transient that remain for around minutes to hours, or sometimes for 24 to 48 hours. And sometimes it may cause large local reaction. Sometimes there could be a large reaction to the sting. And if it is present for a prolonged period of time, it could cause secondary bacterial infection. So what could be the pathology? Earlier presentation, we have seen that for anaphylaxis, first, it could be a IG mediated or non-IG mediated if it is systemic reaction. For local reaction, it could be mast cell degranulation. So it will release the histamine and other vasoactive peptides, and it will cause local reaction. Sometimes venous component itself can cause inflammation and tissue injury. So if it is a delayed kind of reaction, then it occurs in hours on day, or that could be a delayed kind of. So sensitized T cells can cause such kind of cell mediated delayed kind of reaction, or alternate process triggered by venom itself can cause delayed kind of reactions, like a formation of antibody antigen complexes. So it will present with the redness and swelling around 1 to 5 centimeter at the site of sting, and that develop within the minutes and remain for 1 to 2 days. So uncomplicated local reaction may be treated with cold compresses. So you need to apply ice, not direct ice, on the clothes for a few seconds and continuously get it applied. So that will decrease the local spread of venom, as well as that will decrease the redness and sign of inflammation. In spite of that, it is not going. We will see further how we can treat that kind of local reaction. So local reaction to the ant bite, how to differentiate. Have seen that sting bite reaction. Now this is a pustular kind of reaction present with the ant bites. So the site of sting is intense pleuritis, where the sting bite can cause intense pain, and later on it can cause pleuritis also. But for ant bites, it can cause intense pleuritis and local redness. So unroofing of lesion can cause secondary bacterial infection. Basically, that sting bite and ant bite are sterile bite. But if it is contaminated by soil or any other substance which could be potentially infective, then it can cause a secondary bacterial infection. So we can see the difference between the local reaction. So what is a local large reaction to the insect sting? So basically, out of 100% of people, 10% people will develop such kind of local large reaction. What is it? So it is presenting the redness and swelling gradually enlarge in 2 days and usually resolve in 5 to 10 days period. So swelling typically measure approximately 10 centimeter in diameter, and basically it is IgA mediated. So this is known as local RAS reaction. So what is the treatment of local reaction? Basically, you see, it is a symptomatic treatment. So pain is intense, so you can apply the cold compresses, or if there is a swelling on the limb, then raising the affected limb. And probably with this, if it is not going, we can give a NSAIDs. So this could relieve this pain and itch. So antihistamine medication for immediate onset of itch. So delayed onset of itch, topical steroid applied every 4 hours. So itch, basically, if itching is more than pain, is suggestive of allergy. Suppose if a pain is increasing in intensity over a period of days and it associated with a fever, that's suggestive of infection or inflammation that occurs in 3 to 5 days, and that can lead to cellulitis. So what antihistaminic we will prefer over here is basically non-sedative antihistaminic like a cetirizine or fexofenadine kind of. Second is what kind of topical corticosteroid we will ask to apply to patient is, first we can go with a hydrocortisone. If it is a phase bite or something, then we can apply hydrocortisone 0.5 to 1%. Second, triamcinolone, this kind of 0.5%, the cream are available, cream or lotion are available, that we can ask. Third is, if it is limb bite or other bites, other limb bites, then we can ask to apply just more potent corticosteroid every 2 to 4 hourly. That could be a betamethasone or clobetasol, that is 0.05%. So this will prevent the itching, intense itching post bite. So regarding antibiotic, though they actually required antibiotics, suppose we have removed that sting within several seconds or minute, and we take care of that sting with a local antiseptic, then probably it will not require to start with antibiotic. But if we suspect that there is a potential risk of infection, definitely we can go with a preliminary antibiotic. Regarding tetanus booster, if it is contaminated with the soil, then yes, the tetanus booster is recommended. If it is not, and child has already received the vaccination, then tetanus booster is not necessary, because stings are very superficial. I just discussed it is most epidermal rather than deep dermal. So how we could prevent this bee and wasp stings? So wear protective clothing. So those who are in profession of honey production, they may protect themselves by wearing protective clothing to minimize the exposure of stings. And sometimes strong scents, they attract the insect, and that can cause the sting. So how do we prevent local reaction in predictable settings? Suppose someone got sting, and how he will prevent the local large reaction? So he or she can take a single dose of prednisolone, 2 milligram per kg, maximum 60 milligram. And second is topical steroid with 2 hours of the sting. So every 4 hourly need to be applied. So now we will discuss what are the systemic allergic reaction and anaphylaxis. So basically, venom-induced anaphylaxis involves sign and symptom distance from the site of sting, and typically involve more than one organ system. Sometimes they may not present with a rash, and they just present with the systemic symptoms. And we are confused whether it is basically cardiovascular in origin or respiratory origin, but it is actually sting, which is unnoticed. So what could be the symptoms? Symptoms of the skin is generalized urticaria. They will present with an intense flushing, pruritus, sometimes angioedema, but other organ systems are not so much involved, like cardiac system, respiratory system, and GI system, or hematological system. Is known as cutaneous systemic reaction to the venom of the sting. So these kind of patients are presented 10 to 20%, 10 to 20% of patient having only sorry, it is 80 to 90% of patient present with the skin symptom, whereas 10 to 20% of patient have no skin findings. So how the other systemic reaction with them they will present is respiratory symptoms. So just post bite, there could be a hardness of voice or upper airway obstruction due to edema of the pharynx or epiglottis, or there could be a shortness of breath and wheezing due to bronchoconstriction. Second is cardiovascular symptoms. They just present with lightheadedness to hypotension, shock, or circulatory collapse, or due to anxiety as well. So adults tend to have more severe systemic reaction as compared to the children, and absence of cutaneous manifestation is associated with the more severe reaction. That to be noted. So what is the acute management of anaphylaxis? Sir has already discussed regarding the acute management, but I would like to just emphasize what is the main focus on the acute management. So injection epinephrine is a life-saving that need to be given in a recommended position, lying down position on anterolateral thigh as an initial drug of choice. And second is to maintain the airway. And if there is a hoarseness of voice or laryngeal edema, SOS intubation, immediate intubation is required if there is impending airway obstruction. So what could be the dose of epinephrine? It is a 1:10,000 dilution, 0.01 milligram per kg IM injection. Maximum dose is 0.5 mg per dose. If there is a no response or response is inadequate, the injection can be repeated in 5 to 15 minutes. In spite of 3 doses of IM epinephrine, there is a no response or partial response, then prepare for IV epinephrine. So what is the other treatment? The things need to be done. Place a patient in recommended position. If tolerated, elevate the lower extremities. Give oxygen with a NRM mask, 15 liter per minute. Normal saline rapid boluses if there is a poor perfusion like 20 to 10 to 20 ml per kg according to blood pressure and the heart rate and the feeling of pulse. If there is a wheezing, then we could start with the bronchodilators. H1 antihistaminic. Diphenhydramine, I think, don't get in India. So we generally give a Avil, injection Avil, which is commonly available. So pheniramine, that is dose is 0.5 to 1 milligram per kg, maximum 25 to 50 mg we can give. Then S2 antihistaminic ranitidine IV 1 milligram per kg, maximum 50 milligram we should give. Glucocorticoid, consider giving methylprednisolone 1 milligram per kg, maximum is 125 milligram IV if such kind of reaction is happen. I am talking regarding systemic reaction, and we need to do monitoring, hemodynamic monitoring, urine output monitoring, and pulse ox monitoring. So in spite of that, the patient is not recovering, so not responding to IM epinephrine. So we should start with a epinephrine continuous infusion, 0.1 to 1 microgram per kg per minute, and titrate to the effect. Second thing, we can add on with other vasopressor. If child or adult is persistently hypotensive, then we can add noradrenaline or vasopressin. Those who are on patient on beta blocker, sometimes cardiac patient, or those who are on antihypertensive on beta blocker, they do not respond to epinephrine. So drug history is very must to take, and the can be given 20 to 30 microgram per kg of glucagon, maximum 1 milligram IV over 5 minutes. Rapid administration of glucagon can cause vomiting. So regarding this, and to prevent further episode of future sting, so sometimes we suspect that there is a further chances of anaphylaxis or systemic reaction, and the patient is more vulnerable because he use in such kind of setting, he is having a multiple stings and he could have. So venous immunotherapy is available to prevent anaphylaxis in future settings. So we should refer such kind of patient to allergists for further treatment. What are the unusual reaction? Basically, hymenopterin occasionally cause delayed onset and immunologic and idiosyncratic reactions such as serum sickness. They present with the joint pain, fever, lymphadenopathy. They could present with the vasculitis of other organ system like nephritis, vasculitis, neuritis, myocarditis, encephalitis, cold urticaria, and blistering reaction. Sometimes blistering reaction with the sting associated with the celiac disease. Onset typically occurs days to week after the sting, as most of this reaction arise from tissue deposition of antigen antibody complexes, which precipitate only after sufficient antibody has been formed, those who got a repeated episode. There could be a toxic reaction from the numerous sting. There could be multiple bees which has been stung to any individual in a one setting that can cause a sustained massive envenomation, and there is no specific antitoxin available for the treatment of hymenopterin sting. Only supportive and intensive care monitoring is required for them. So just I want to conclude my talk to again thank my seniors and MAHAIAP for this giving me opportunity for this talk. Thank you so much.
So it was a very lucid talk, Nirojan. So again, Mohite sir, your expert comment for this.
Yeah, I think again, Dr. Mishram has really covered it extensively. Not much to add to that. Just one thing, I think three of the speakers have spoken on anaphylaxis during the course of their talk. One thing we want to again re-emphasize, adrenaline, 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 and intramuscular. Adrenaline is to be given intramuscular. You cannot really give the IVs for two reasons. One, AVs are collapsed. It's very difficult to get dilated at that point of time. So if you don't have an access, then attempts in fact, intraosseous, because intraosseous veins don't collapse. And secondly, IV has very high chance of arrhythmia potential. If you give adrenaline IV, there is very high chance of arrhythmia potential. So that's the last resort. It has to be given intramuscular. In fact, the first dose can be given around if you are given some injection and following that he has acquired anaphylaxis, maybe first dose can be given around that area itself. So intramuscular adrenaline is the things. As far as bee wing and wasp sting is concerned, we are seeing those problems in the city premises nowadays because the tall buildings, there are those bees kind of nets are created, and suddenly people they come to burn it to get the honey out of it, and there is a lot of bees they spread around. And small children they may be getting bitten, and yes, at times we do see anaphylaxis also related to that. Though not, I have not seen many cases, maybe one or two in my whole career of say 35 years. Not very common problem anaphylaxis, but yes, multiple these can give rise to angioneurotic edema kind of a presentation or whole swelling and all those things. So be prepared with those. Rest, I think Dr. Meshram has really covered whole aspects extensively. Good and congratulations IIP Maharashtra for taking such odd topics because I don't think many of us go particularly and read these topics. So this is a good kind of a revision and revisiting of our basic sciences. Thank you very much.
So I invite next Dr. Ujjwala Shirsat ma'am from Ahilya Nagar to present her something different now from anaphylaxis, from allergies and rash. So we don't have allergic rabies till now. So let us see what ma'am has to say about rabies.
Respected guys, good evening to all. Thank you, MAHAIAP, for this opportunity to celebrate the colors of festival in very unique way. So let's
Ujjwala,
see.
make
My
it full
topic
screen.
is rabies.
Make it full screen, Ujjwala.
Yes.
Ujjwala, you can just
Click on the
click on
slideshow
the slide share button.
Yeah, yes, correct, madam, correct.
Yes. Done.
Yes,
Okay.
thank you.
Okay. So let's coming to the case scenario. First, we will start with the one case scenario. 5-year-old male child came with the rabid dog bite history on face and right trunk and cheek. The child was active, conscious, and pain was present at the local site. Vitals normal. On admission, the local wound care was taken, IV fluids, antibiotics was given, injection Rabies shield was given here, and half dose over the wound and the half of the dose in intramuscular. The injection Indirab stat dose was given, and the investigations like CBC, RFT, LFTs, and also pus culture was sent. So in brief, I want to brief the rabies. Rabies is a zoonotic disease caused by the Lisa virus transmitted to the human being by bites from the rabid animals. The rabies virus is neurotropic. Virus enters the peripheral nerves or the cranial nerves from the damaged nerves, ending from the site of the bite, and it ascends up through the dorsal root ganglion, spinal cord, and finally reaches the brain where it multiplies enormously. The rabies virus is subsequently descend down to all secretory glands like salivary glands, mammary glands, sweat glands, urine via the sympathetic nervous system. And since there is no viremia, rabies virus cannot be detected in the blood. After an average incubation period of 30 to 90 days, a clinical symptoms of hydrophobia occurs. There are two forms of rabies in human. The classic hydrophobia, aerophobia, photophobia, the clinical course about 1 week to 10 days. The more remarkable abnormalities are the agitation, photophobia, priapism, increased libido, insomnia, nightmares, and depression may occur. It's suggesting the symptoms like encephalitis and brain, some psychiatric condition disturbances. In paralytic rabies, we can see the different like ascending paralysis, the clinical course about 3 weeks. Death invariably occurs due to the cardiorespiratory failure. Around 20 to 30 patients presented as encephalitis in our set. So human rabies is the almost always fatal after the animal bite, and it can be prevented by either pre-exposure or the post-exposure prophylaxis. So we often forget about the pre-exposure prophylaxis. So I want to brief about it. Pre-exposure prophylaxis is recommended for individuals at higher risk due to the occupation and for children in endemic countries like India. Rabies vaccine can be administered by 2 different sites. One is intradermal and intramuscular route. There are 2 routes, and according to the different schedule, for young children less than 2 years, the anterolateral area of thigh can be preferred. In intramuscular, we can follow the schedule of 0, 7, and 21 days into anterolateral aspect of thigh. In intradermal, 0.1 ml of vaccine on days 0, 7, and 21 or 28 in deltoid or anterolateral thigh. The 2-side intradermal administration of rabies vaccine has also been recommended on 0 day and 7. So coming to my topic, which is post-exposure prophylaxis, where we need to categorize the wound, depend on whether it is in first category, whether it is touching or feeding of the animal or leaking on the intact skin. We can take it as a exposure none, and if reliable case history is available. In category 2, if nibbing of uncovered skin and minor scratches, abrasions without bleeding, it is minor exposure. The local treatment of wound is needed, and we need to administer the anti-rabies vaccine here. In category 3, there might be the single or multiple transdermal bites, scratches, leaks on broncho. It is categorized as the severe. We need to go for the human rabies immunoglobulins patient with dog bite. So local treatment of wound. We can see in this picture, all animal bites should be washed for 10 to 15 minutes with the copious amount of water and soap. And after allowing the wound to dry for a few minutes, antiseptic like povidone, iodine, and surgical spirit should be applied on the all wound to chemically inactivate or kill the rabies virus at the site of bite. Rabies risk is increased almost 50% by early, is reduced to almost 50% by early and local treatment of the wound. The routine suturing of the wound and surgical dressing recommended. Few stage sutures can be applied to the stop bleeding on infiltration of immunoglobulins or monoclonal antibodies into the wound. The administration of rabies immunoglobulins. It is passive immunization. For individual with the category 3, we have seen already the category 3, the severe exposure vaccine alone is not enough. And additionally, the immunoglobulins or the monoclonal antibodies is indicated as the vaccine induced antibodies appear after 7 to 14 days. During this window period, 7 to 14 days, the patient is unprotected. Hence, the immunoglobulin and antibodies need to be administered. This is administered only once as soon as possible after the animal bite and not beyond the day 7 after the first dose of vaccine. In rabies immunoglobulin or monoclonal antibodies are also indicated in the category 2 in immunocompromised patient. So there are 2 classes of rabies passive immunizing agent. First, rabies immunoglobulin. In that equine rabies immunoglobulin, the doses are like 40 international unit per kg body weight, and it is indigenously manufactured to be used only after the skin sensitivity test as per the product insert. And second one is human rabies immunoglobulin. Dose is 20 international unit per kg body weight, and it is really expensive and imported, and no skin sensitivity is required in this. It is available in pre-filled syringe. In nowadays we are preferring the Rabies shield, which is rabies monoclonal antibodies. The human that is single Rabies shield Dose is 3.33 international unit per kg body weight, and potency is 40 IU per ml. Monoclonal antibodies is Docetaxel and Miromavumab. The dose is same for dose is 40 international unit per kg body weight, and potency is 600 international unit per ml. So rabies vaccine for post-exposure prophylaxis can be administered either, we can see here, the demonstration is given in this image. Intramuscular route, the one dose of vaccine administered on the 0, 3, 7, 14 and 28. Either we can give it in intradermal route. 0.1 ml in two sides, in both arms we can give 0, 3, 7, 28. In less than 2 years, we can use the site anterolateral thigh also. No condition including the pregnancy. Also, there is no contraindication for the post-exposure prophylaxis. It is safe in all ages. Supportive therapy, tetanus containing the vaccine if indicated as per the previous immunization status, and anti-inflammatory antibiotic depending on the type of wound can be given. Post-exposure prophylaxis for rabies exposed individual who can document previous either pre-exposure prophylaxis or the post-exposure. Only 2 doses of vaccine on the day 0 and 3, either by intradermal or intramuscular route. No immunoglobulins indicated or no monoclonal antibodies needed. Per site, intramuscular vaccine administration on the day 0 and 3 or intradermal 0.1 administration on the day 0, 3. If repeat exposure occurs, re-exposure within the 3 months before the completion of the post-exposure prophylaxis, only wound treatment is required, neither or nor RIG needed if it is within the 3 months. So this is the flow chart. These are the WHO guidelines given in 2019. After that, IAP action plan already described in detail in 2022 for the kids. And in these WHO categories are there. It is difficult to understand actually. The WHO category, for first category, no PEP is indicated. For category 2, only no PEP indicated. Washing of the wound is sufficient. If needed and patient is immunocompromised, we need to go for the RIG. And in category 3, WHO category 3, there is need of rabies, anti-rabies vaccine also and immunoglobulins also. So there is one video. Pallavi ma'am, can you please play this video? This is the video.
Yes, ma'am. But you have to stop the sharing.
Okay, just
you have to stop the sharing, then I can share the video.
Okay, just a minute. I want to discuss one case scenario. So actually in district hospital, we have so many cases of dog bite, rabid dog bite, and very unfortunately, we got 2 patients, those who died with the rabies encephalitis. Already they got the ARV, already they got the ARS, still after that they died. So I wanted to discuss this case in brief. The 4-year-old child Ayush Yadav, resident of Anandwadi, suffered from the rabid dog bite over the scalp and face in December month. Bleeding present, category 3 dog bite, following which he was shifted to the Dound Hospital RH, and wound was cleaned due to unavailability of ARV. Patient was referred to our hospital, Ailanagar, on the same day, and he administered ARV also, and as well as the ARS also around the wound, and he was admitted with us for 8 days, civil hospital. After discharge, patient was absolutely all right, almost 7 to 8 days, after which he suffered with the fever. For the same day, he visited to the Srinath Hospital, Kashti, and the primary treatment was given and patient was sent home. The same day, fever didn't subsided and patient was taken to the another doctor, where the patient was admitted for 1 day and referred to the Sasun Hospital. In Pune, Sasun Hospital for further management, the patient was referred to the Naidu Hospital for critical care, and actually very saddened to say that the patient was expired after giving the ARV also and ARS also. This is the picture of patient. This wound was quite deep. We got this CSF report from Sasun Hospital. The CSF analysis, RT-PCR was done. It was human rabies. And we got this cause of death also, rabies encephalitis. So for seniors also, I want to discuss this case, and I think this is a good opportunity for me. because we are seeing a lot of patient dog bite. We need to, we got so many complications after this case, actually, because there are so many problems arises. तारांकित प्रश्न झाला तो विधानसभेमध्ये. And I think this is eye-opener for all pediatrician, all of us. We should keep the record of animal bites. We are very poor in record keeping like animal bites, and there are guidelines. When we came to know that, when survey was going on, when the inquiry was going on in district hospital, they asked about the total record of animal bites, and there the epidemiology of animal, epidemiology of the animal rampantness, then their vaccination, everything was noticed by the survey officer. And I think we should go in depth, and our guidelines should be according to that also. I think I'm very happy to share all these slides, and I'm very happy to get this topic for discussion. Thank you, MAHAIP, for this opportunity. Pallavi ma'am, please, can you play the video?
Yes, ma'am. Yes, ma'am. I'm stop sharing your PPT so that I can share.
Yes, ma'am.
Vaccine. The prerequisites for giving ARV vaccine: a pair of disposable gloves, vaccine set, distilled water vial, 1 cc syringe. We are giving third dose of ARV vaccine. It is administered intradermal. Intradermal vaccination, either sides of the hands are used. 0.1 ml is administered on either sides of the hands.
Thank you so much.
So rabies is a very close topic for me. We have presented the 31st surviving case in the world from rabies. So we had published this case in an international journal. So it's always a very interesting topic for me because of this thing. So first, Mohite sir, can you just get some few points on this thing? And I would also like to add some things which we can discuss later.
Again, a very good presentation by Dr. Ujjwala. Just now, Nikhil said the 31st case of survival, but as I remember, or as I am aware of the literature, neuromorbidity is almost certain. Almost certain. So whatever case is survival, it's not still conquered. So it's always the prophylaxis, which is the treatment, or probably the only treatment for intact survival. That's one thing. Second, it is not only caused by dogs. The cats are equally bad. The monkeys, the wild animal bites are equally bad. So whenever any doubt, you be very aggressive in giving post-exposure prophylaxis. Whenever you're in doubt, be aggressive in giving immunoglobulin as well as antigen both. Pre-exposure prophylaxis, you said many of us are, our patients are having dogs and pets at home. So if you really want to keep them at home, take a prophylaxis prior to getting them at home, and every member of the family should be given the prophylaxis, mind you. So 0721 is absolutely mandatory. 21 or 22, that's absolutely mandatory if you're going to keep any pets at home. Sorry? Hello? Yeah. As far as post-exposure prophylaxis, there's a debate at present going on about 037 and the fourth dose between 14 to 28. So either it's fourth dose or 5 dose also. IIP recommend 5, WHO is on 4. Probably WHO has got reasonable evidence to say maybe over the time IIP also guidelines may change. The old understanding that the wound should never be closed is now out. There's enough evidence and up-to-date clearly mentions that if the wound is clean, especially if it is on the face and the patient comes to you within first 24 hours, we will suture the wound. Only thing is, don't take the deep sutures, take a superficial sutures. If it is on the body and the limb, the suturing can be done within 12 hours if it comes. Of course, you ensure that there is no foreign body like broken tooth or something inside the wound. Ensure that the wound is properly cleaned and no infection left inside, and then go ahead and treat. Antibiotics, yes, whenever you suspect it, patient is coming late or there is an infected wound, then definitely you have to give it. The last case which Dr. Ujjwala mentioned about after giving immunoglobulin, the patient died. Even I had the similar experience where the patient took immunoglobulin and vaccine from the government medical college or government hospital. And then after almost about 2 weeks, they landed. Very classical picture, and even that child died. When we inquired, the child had received probably horse serum. That's something we are definitely having doubts about the potency, efficacy. We have gone into the research literature also. The efficacy is not 100% in a immunoglobulin derived from horse. And now with the availability of monoclonal antibodies, now you mentioned about a particular brand which is single potent, but there is a single valent, but there is another one which is a polyvalent as well. And if their efficacy is again almost equal. And most important, it is not at all prohibitively costly. It's quite economical. So keep a very low threshold for giving immunoglobulin in a post-exposure prophylaxis. You are having slightest doubt about any licking or kind of a bite on an open skin mark, you go ahead and give it irrespective of whatever pre-immunization status. Another thing, justification given by the parents, sir, वो dog pet dog ने काटा है and dog घर का है उसको immunization दिया है. If there is a type 2, type 3 wound even from the pet dog, be very aggressive in giving immunoglobulin as well as antigen. So because the vaccine which is given to the dog, whether it is given in the right time, whether it is potent, which brand, all this very difficult for us as a clinician. So always convince the parent that if want near 100%, then go for both and complete the course. So that's how I will take it. I think it again, all 5 presentations were really very good. Dr. Ujjwala, your presentation also was excellent. Thank you very much. Thank you.
So I would like just to add few points to this. So we saw about intradermal vaccines. So one thing is the intradermal is used usually in the mass vaccination. So whenever you are using it in your personal clinic, it is much better that we recommend to take a complete dose of the vaccine. Because anyways, if you're giving 0.1 intradermal, the rest of it is going to go waste. So for private practitioners, it is recommended to give intramuscular. The intradermal is usually for mass vaccination. So whenever for the government setup of the civil service. One more thing is now that the latest recommendation are we don't give anything intramuscular. So what we do is we calculate the anti-rabies, even if you use a monoclonal antibodies or you use a human immunoglobulin, what we do is we try to infiltrate as much as possible, and there is no role for an intramuscular injection for the remaining thing. So that thing has to be kept in mind because the problem comes when if the wound is large and the amount of antibodies is less, and that thing you can dilute it more. As far as the last case is concerned, I think they were unlucky to have the site, the face, and the scalp. These are the nearest to the brain, and it has the shortest incubation period. And again, as Sir has said, the anti-rabies serum which was given and how much potent it was should have made the difference. So thank you. So any questions?
Yeah, Dr. Veena sir had want to add something.
Yeah, this
Yes,
is
sir,
with
please.
regard. Yeah, this is regard to cat bite and anti-rabies vaccine. See, often our patient says, "Sir, ये cat तो vaccinated है, फिर क्यों आप vaccine दे रहे हो?" The answer is very simple. The seroconversion in the vaccinated cat is maximum up to 60%. So it's never 100%. So even if the cat is vaccinated, it is recommended for want of incomplete seroconversion to administer anti-rabies vaccine. That's from my end.
The important take-home message is that vaccine is protection for the cat from rabies.
Yes.
It doesn't protect us from rabies.
Yes.
So
that's
you
important.
have to, so irrespective of the vaccination, it is the category which will decide the treatment.
Yeah.
Mohiti sir, can you add anything regarding the bad exposure rabies? One question is there from our attendees.
In Indian scenario, bat exposure is not found to be delivering rabies. Rodents are not exposed. Like commonly questions is rat bite हो गया rabies देना है क्या? So rat bite doesn't cause it. Okay. So in Indian scenario, it's cats, dogs, monkeys, wild animals. That's all. Even bat is not. In a Western world, yes, they have documented. In the Indian scenario, it's not documented.
Thank you, sir.
Sir, one doubt is there. If it is around eyes, what we can do? Most of
You'll
the
have to
patients got it
you'll
around the
have to
eye.
infuse. You'll have to infuse around the skin, around that
There
wound.
are,
What
so
Nikhil said is perfectly right. It has to be infused around the wound.
So even for the corneal things, what they recommend is you use it in a spray form, or you irrigate the cornea with the anti-rabies serum. What is important is the local thing. So there are only one or two conditions where we use the spray. What we do is we take the serum, we put it in a spray, so it's cornea or any mucosal involvement. So oral bite and there. So even there you irrigate it, or you make a spray and put it. It's the local thing which makes an effect.
Okay, sir. Thank you.
Regarding the rabbit bite, do you want to add anything, Vinas sir, regarding the rabbit
Hello,
bite?
yes. I'm not sure about rabbit bite and rabies.
Mohite sir, you
I'm
want
very
No,
honest about
no.
So
Even I have
what?
not heard about it.
No. So what
any
we
special
have?
precaution for human bites?
Again? No, not
Protocol
required.
for human
Definitely
bite?
not
Not
required.
required.
Nothing to do?
No, not required. Not required. Not required.
So again, there is a question about rabbit cow milk. So there is no documentation for that. Even human to human transfer. So treating a rabies patient, there is no documented. Ideally, everyone should be protected with the vaccine who are treating a rabies patient. But there are no cases documented for human to human transfer of rabies. Leopard
No,
bite, it is
one
there.
precaution. Yeah, just one precaution when you are dressing a wound, rabies wound, definitely take the universal precaution. The gloves and all, definitely mandatory. Very important.
One question is there. If a child is immunized, then immediately gets a bite in little time, do we restart 2 doses for a previously immunized person?
First 3 months, nothing. Beyond 3 months, 2 doses.
Thank you.
As well as
0, 3. That's all.
No more questions.
Leopard bite. So leopard bite we have to give. So that was the last question, one of the last. So leopard bite, it comes under the wildlife, and you have to give a rabies vaccine.
Mahesh, even the large rodents doesn't need the PP.
Snakes?
Large
No. Snakes, you said, huh? Snakes? No.
large size rodents.
Large size rodents also no. Indian, at least scenario, rodents are not not known to transmit rabies. So all rodents, no anti-rabies prophylaxis.
So essentially, it is the carnivorous animals where we have to be worried about the rabies. The
Right.
carnivorous animals.
Right.
Yeah. So, Sachin, it is 11 o'clock.
Yeah.
We should wind up now. So
Yes, it was a
it's
very
now the
detailed
last
presentation.
stage of the academic session, the vote of thanks. I'm honored to propose the vote of thanks for this scientific session on behalf of MAHAIP. We extend our sincere gratitude to our esteemed expert, respected Dr. Mahesh Mohite sir, for sharing their invaluable expertise and enriching our understanding of pediatric emergencies. Your contributions have made a lasting impact on this session, sir. We deeply appreciate our distinguished speakers, Dr. Deepika ma'am, Dr. Rohan, Dr. Jitendra, Dr. Mesham sir, and Dr. Ujala ma'am, for generously sharing their knowledge and expertise with us. Your contributions had greatly enhanced our academic session. Now, we extend our heartfelt thanks to the organizing team from MAHAIP, especially Dr. Sanjay Pakmode sir, Sanjay Deshmukh sir, Amol Pawar sir, and all the EBs and CIP who are tirelessly making efforts for these academic sessions and for getting the MMC points also. Here I want to thank respected Dr. Rajendra Kulkarni sir, who is a MMC observer for today's session. I want to thank each and every one of our attendees for their active participation, engaging discussions, and enthusiasm, which made this academic session a memorable experience. So your presence and contributions have enriched our session. Once again, I thank you each and every for this academic session. So thank you once again. Good night and Jai Mahayap.
Sachin, thanks to Nikhil Pathak, our AB member who has been generous to be part of this
Thank you,
program.
Nikhil, also my colleague moderator. Thank you, Nikhil.
Thank you,
So it's
Dr.
a pleasure to
Minhas
be
also.
here.
Thank you.
Recording stop हो गई
Thank
अभी
you,
आप
sir.
लोग
Thank you.
बोल